Sir. Good evening, sir.
Hi, good evening. How are you?
Fine, sir. Yes, sir.
Okay, great. So we can start, huh?
Yes, sir.
Sure. So this is, as you know, mock test,
Yes, sir.
and we have limited time for CCS, as in EDIC part 2. So
Okay.
30 minutes for one CCS, right? We will
Okay,
start
sir.
now. So,
Yes.
it has some 5, 6, one case and 6 VNet. And there will be about 4 to 5 questions in each VNet. So you need to answer. You will be given adequate time for each question.
Okay,
Okay.
sir. Okay, sir.
Shall we begin?
Yes, sir.
Okay, great. All right. So this is a neurology CCS, and this is your case here. You can switch on your video, please, Dr. Archana.
Yes, sir. Sorry. Okay. My video is not there. 1 second, sir. Is it okay,
Okay,
sir?
doctor. Yes. You are visible now.
Yes.
So now you can read, or you can no need to read. Just assimilate the information from this whole
Yes.
scenario.
Yes. Sorry. The lower thing is not seen. Neck stiffness.
Yeah, it
The
is visible.
last part is not seen. Neck stiffness is there or not, sir? I couldn't see. Yeah, neck stiffness is present. Okay, sir.
Okay. So you have this history, then vital signs and physical examination.
Shift hypertension, also emergency with sudden severe headache. Yes, sir.
Okay, we have it.
Yes.
Okay. Now we start the questions based on this VNet.
Yes.
So provide a list of 3 grading skills to categorize the severity of this patient's condition.
First thing is CT severity scoring. Will and FES the scoring, and the other one is my provisional diagnosis is subarachnoid hemorrhage in this patient, sir.
Okay.
So yes, the CT
Okay.
severity scoring, the wheel and the FES, and the other one I just.
Okay. No problem. So you have 3 grading, most commonly used grading to categorize the subarachnoid hemorrhage severity.
Yes, sir.
Okay. So you have.
The Hunt and the Hess classification.
Okay. Great.
Yes.
Okay. Now, next question. What are 2 immediate active issues in this patient warranting critical care referral?
One is the blood pressure, which is the blood pressure is very high. The patient is drowsy. Like if I'm going from the head to toe, his GCS is low. He is drowsy, and in the vitals parameter, his blood pressure is very high, and he needs an ICU care and a critical care reference for further care of this patient.
Okay. Okay. Very well.
And
Now,
yes.
yeah, you want to add something before we go
And
to, you have
my
adequate
provisional
time.
diagnosis is subarachnoid hemorrhage, which needs an intensive care referral.
Okay. Okay, great. So now, please list 5 important initial investigations needed in this patient.
Yes, sir. First investigation, I already have the parameters. I would like to go with the complete blood count and the routine blood investigations. Second, I'll go with the CT angiogram. If his creatinine is normal, if his creatinine is if it RFT is elevated, or if he has impaired renal function test, I will just go with the plain CT of the brain. And if yes. These will be my first 2 main investigation. Based on these 2 investigations, I'll go with the next steps.
Okay. Okay, all right. Now, what are 2 early complications that are expected in this case?
The two early complications are uh, I'm repeating it is the main thing is he may have a worsening of GCS. He may go for a ventilator parameters. Otherwise, worsening of the bleed because of his hypertension can be the first early complication, and is his worsening of his neurological status. All the other things will be a step-by-step next complications, which will be the hydrocephalus, the hyponatremia, the vasospasms, or other things are I expect in due courses.
All right. Okay. Now we'll go to the VNet 2. So CT scan of the head of this patient reveals a hyperdense area in the subacnoid space. Then later CT angiography shows a 7 millimeter anterior communicating artery aneurysm as a source of bleeding. And the lab investigations are all normal. CBC is normal, lights and RFT coagulation all are normal.
Okay, sir.
Okay, so
Yes.
we will go ahead with the questions based on this.
Yes.
Okay. List 4 early management strategies in this case.
So the first management strategy will be protecting the airway for the patient. If he is not protecting the airway, I will go with an ventilators. That I will go for an invasive intubation and protect his airway. Next step will be his management of his vitals, mainly the blood pressure control. Third thing will be hydrating the patient adequately. Yes. Fourth thing will be prevention of further neurological deficits. I will go for an early like an anti-epileptic and anti-edema measures and an imodipine, anti-vasospasmatic for a probability and imodipine.
All right. What are 2 important measures to prevent rebleeding?
Prevention, yes, prevention of avoiding increased BP, like prevention of and worsening of hypertension, and early intervention. Like if there is a need for a clipping or a coiling, I will go for an early intervention, sir.
That's nice. List 2 commonly used drugs to control blood pressure.
I'll go for a beta blocker and an NTG if needed.
Beta blocker and NTG.
Yes.
All right. What are 2 benefits of endovascular treatment in this case?
The main benefit is prevention of a rebleed, sir. Avoiding a rebleed will be the main benefit of endovascular treatment.
All right. Okay. Any other benefit of endovascular over surgery or something like that you would like to add some more? All right. You have time.
Okay. Other than prevention of a rebleed,
and what are the benefits over the surgery? Any long-term outcome benefits or short-term benefits? So there are 6, 7 benefits. Okay. All right, no problem. What are 2 main indications of surgery in the case of SCH?
so surgery, if there is a gross cerebral edema and if we need a decompression, we will go ahead with a decompression, sir. And second thing is if the aneurysm is not in an approachable space, and if the neck of the aneurysm is very broad or if it is not approachable with an endovascular treatment, I will like to go ahead with an surgical based management for an SAH.
Okay. Okay, so these are 2 main indications for craniotomy and clipping.
Yes, sir.
Okay. List 4 early management strategies in this case that we have completed. So now last 2 main cardiovascular complications.
Patients can have any kind of arrhythmias, like a bradyarrhythmia or tachyarrhythmias. and patient can also go for heart blocks in these patients. Any kind of arrhythmias, which can be brady or tachyarrhythmias, are the most common form of cardiovascular complications.
Any other issue? Yeah.
And kind of these patients can present like an MI patients, which there can be some kind of elevations of an ST elevations kind of MI features, but it may not be an exact cardiovascular event, but it can be a replication of the SAH.
Okay. Okay, that's great. We'll go to the next vignette. So this is vignette number 3. The patient is admitted to neuro ICU for close monitoring, and blood pressure is managed with intravenous labetalol to maintain a target systolic blood pressure of less than 160 millimeter of mercury. A neurosurgical consultation is obtained and a decision is made to proceed with surgical clipping of the aneurysm. He undergoes a craniotomy for aneurysmal clipping, but intraoperative aneurysm rupture leads to significant hemorrhage. Efforts to secure the aneurysm are unsuccessful and the patient is transferred to neuro ICU for post-operative care. Patient is intubated and sedated on mechanical ventilator. All right.
Yes, sir.
So based on this information, here are the questions for you. What are 2 preferred sedatives for use during mechanical ventilation in this case?
I will like to go ahead with now benzodiazepines, because it prevents seizures and as well as a good sedative. So I will go ahead with midazolam preferably. And what we commonly use is a combination of an opioid and benzodiazepines to calm the patients.
Okay, great. What are 4 immediate post-operative principles of management in this case?
Yes, sir. As this patient has not been clipped or coiled, the definitive management has not been done. Again, I will like to go ahead with the complete blood pressure monitoring, blood pressure control. Calm the patient, avoid bucking, avoid any kind of stimulations on the ventilator, like any bucking or patient is struggling on the tubes. Avoid any like coughing, bucking, anything on that way, and avoid any vasospasm, so that I'll add nimodipine or calcium channel blocker along with it, and watch for any arrhythmias and on the monitors. Avoid any kind of arrhythmias. So the main things will be ventilator management, blood pressure control, keep the patient calm and avoiding the vasospasms, and keep monitoring for further complications like hydrocephalus, hyponatremia. And in the meantime, I will also go ahead with an electrolyte monitorings like any hyponatremia and other things with the routine monitoring, because and also he had a huge blood loss. I will like to go ahead with complete blood count again with the hemoglobin monitoring. So if needed, I will also go ahead with blood transfusions as needed.
Okay. What modalities you would employ for neuromonitoring in this case?
For neuromonitoring. So I will first I will go ahead with routine ETCO2 from the basic things. I will go ahead with an ETCO2 monitoring to go keep the patient the ETCO2 within the normal range, and I will go ahead for this for the transcranial Doppler, so that I will look for an vasospasm on and off some with a transcranial Doppler, so that we can prevent or avoid any vasospasm. We can find it in an early way.
Okay. Identify 2 ICP reduction strategies for refractory intracranial hypertension.
Refractory intracranial hypertension. So when the anti-edema measures and other things are failing, I will also go ahead with main thing is keep the patient calm, keep the patient sedated. That will, in general, reduce the ICPs, and maintaining normoglycemia, normocapnia, and normocapnia and normoglycemia with head and
For
elevation. Yes.
refractory intracranial hypertension. Okay. Is there any?
Not sure. Not sure.
Okay.
Any LP can be done. I'm not sure, sir.
Yeah. Very good.
Lumbar puncture, I'm not. I'm doubtful. I'm not sure of lumbar puncture.
Okay, great. All right. So we'll go to next vignette. After 24 hours of stabilizing BP and ICP, the patient successfully underwent endovascular coil embolization for the ruptured aneurysm. Post-procedure, the patient was monitored in the neuro ICU and 6 hours later was extubated. GCS was 11.
Yes, sir.
Okay. The patient
Yes,
is
sir.
extubated and GCS is 11. Now we go for questions. How will you monitor cerebral vasospasm in this patient?
I will frequently go ahead with an bedside transcranial Doppler so that I can monitor the cerebral vasospasm, and any new onset deterioration in SGCS, I will keep monitoring for that.
Okay, great. What are two main predictors of delayed cerebral ischemia?
A high blood pressure and persistent vasospasms.
Okay. Any other? No problem. We have already said two. What are three main drawbacks of hemodilution and hypervolemia that led to the abandonment of triple H therapy in SAH?
So in general, I'm not sure of answer, but in general, there patients with SH, they have a high BP and volume overload. A hypervolemia, a volume overload feature is not going to help them, and it is in general now proven that in hypervolemia, volume overloaded patients have a worsened outcome than a normovolemic patients.
Okay, this is the main drawback of volume overload. Any other? Okay, right. Now we go to vignette 5. Initially stable, her condition worsened on post-op day 2. She experienced a decrease in her GCS to 7, E1, V2, M4. Trachea was reintubated and patient was hooked to mechanical ventilator. A repeat CT scan revealed rebleeding and hydrocephalus. Nimodipine was continued and a transcranial Doppler was performed. An external ventricular drain was placed and levetiracetam was administered for seizure prophylaxis. So with this information, what are two benefits of using TCD monitoring in this case?
So it's a bedside modality of monitoring any vasospasms. So in this patient, as we know, like SAH patients are prone for delayed vasospasms. So the TCD is a main modality in monitoring, as it is a bedside modality, so that we can keep monitoring regularly. Watch for
Okay,
it.
good. One is bedside. Any other benefit?
I'm not sure, sir.
Okay, no problem. What are two main complications of EVD placement in this case?
Complications.
Early or late? You're just asking complications. So, what could be two complications you would like to expect in this patient?
When placing an EVD, sir, like
yeah, while or after, when patient is in a neuro ICU, when you are taking care of patient.
infection, a intracranial infection.
All right. Okay. Oh, no
A
problem.
disease of EVD.
That's all right. Okay. These three main risk factors of seizures in SAH for which anti-seizure medication may be reasonable.
Increased intracranial pressure,
Okay.
a delayed cerebral ischemia,
Any historical risk factor like you would like to see in history and examination related to that? Okay, no problem. Because we are now short of time a little bit.
okay,
Okay. Now, the patient's condition continued to deteriorate despite aggressive management in the neuro ICU. On post-op day 4, she develops worsening of GCS to 4T, E1 M3. Repeat CT scan showed significant increase in the size of hematoma and further expansion of ventricles. She underwent an urgent craniotomy and intraoperative findings revealed extensive blood clots and several severe cortical edema. Post-surgery, her GCS score improved to 8 by 15, but low, prompting close monitoring in the neuro ICU. She was continued on supportive care measures, including hyperosmolar therapy, with mannitol to manage her increased ICP. Despite these interventions, neurological examination remained concerning and she developed fever suggestive of possible infection. The team remained vigilant, collaborating with neurology and infectious disease specialists to optimize her care. The family was kept informed of her precarious situation as they grappled with the uncertainty surrounding the prognosis.
yes, sir.
Okay,
Yes,
can
sir.
go ahead with
Yes, sir.
questions. Very nice. What are four main causes of fever in this patient?
SAH in itself can cause hypothermia. It can alter the temperature controlling mechanisms. Second, she is a post-operative patient at high risk of uh, temperature spikes. Third thing, she has a lot of invasive lines and tubes, which can again cause, and hydrocephalus with an EVD possibly can cause a fever. First, I would like to think of an SAH in itself, which can cause an hypothermic reaction. And second thing is prolonged ICU stay and with multiple invasive lines
Oh,
and invasive lines.
okay. What are three risk factors for nosocomial meningitis?
A post-operative patient, first a patient, this patient has undergone an endovascular treatment and also has undergone a second sitting of a decompressive craniotomy. These are the two main risk factors for a nosocomial meningitis.
Okay. What are three first-line antibiotics for nosocomial meningitis?
First, I will go ahead with an broad spectrum antibiotic. I will go with an meningitic dose of an meropenem, like a 2 gram IV TDS, if a creatinine is okay. Then I will go ahead with an gram positive coverage, like an vancomycin of 1 gram OD. And least thing will be a fungal coverage. The last thing will be, I'll also go ahead with a fungal coverage. So I will first go with a broad spectrum, both gram positive and gram negative meropenem, and I will send a culture of the LP if possible. I will also go ahead with an lumbar puncture and go ahead with a culture of the lumbar puncture and titrate the antibiotics accordingly.
Okay. What factors predict a poor neurological outcome in SAH?
A persistent low GCS, refractory, a rebleed, a hydrocephalus, and a vasospasm.
What are three main predictors of tracheostomy in cases of SAH?
A patient with a prolonged low GCS, a poor GCS even after 4 or 5 days of on ventilator, and whom we predict going to be on ventilator support for a long time, like mainly a poor GCS, and repeated any three main predictors of tracheostomy. Yes, a persistent poor GCS is going to be the main predictor of tracheostomy for me, sir. And any surgeries, repeated surgeries, if she is going to be planned.
Okay, nice. So this concludes our session on CCS.
Yes, sir.
So you did really try to answer most of the questions with confidence.
Thank you, sir.
And we would like to, like tomorrow we will, you know, that will be time for discussion of all these questions one by one. So you will
Yes,
know
sir.
what about how you did.
Yes, sir.
But so far it's good. Only input which I can provide at present is that you have to be really sticking to the point, right?
Fine.
So,
Yes, sir.
so answer only what is asked.
Oh,
That's enough. Okay. And
oh,
if you could give more points pertaining or specific to that question, that's all right. But don't please do not go out of the context if possible,
yes,
because
sir.
that will not add to any point, to your answers.
Yes, sir. Sure, sir.
So that's just one small.
Yes, sir.
Okay. So now we can go ahead with CBA. Okay. I have about 10 computer-based assessment.
Okay, sir.
So I will just go ahead with the CBA now. All right. I'm going to share the another PowerPoint. Is it visible on
Yes,
your
sir.
screen?
Yes.
Okay. Great. So it will just, I will give you about 15 minutes. Okay.
Okay, sir.
Just let me start the timer first. Okay. Now we start. So I will not read it. You read yourself. Okay.
Yes, sir.
And you assimilate information, you need to read loud, and
Okay, sir.
you can answer the questions.
Yes, sir. A 42-year-old male construction laborer presented with emergency with pain and severe weakness in his lower limb. He had no previous comorbidities. His co-workers reported that he had been experiencing intense muscle pain in his thighs and lower back for the past 24 hours. So blood pressure is 140/90, heart rate of 110, respiratory rate of 20, temperature of 37.5 degrees Celsius. He appeared fatigued and weak. His skin is warm and dry. No obvious signs of trauma or external injury. Creatinine kinase is more than 10,000. Serum potassium of 5.3. Urine analysis showed positive for myoglobin. What are the main steps of management? This three differential diagnosis.
So what are the main steps of management? So next time, doctor, no need to read aloud. Okay,
Yes, sir.
because it
Yes.
will save a lot of time. Because in
Yes, sir.
real time, you need not to read aloud. Just
Okay.
assimilate the information quickly while
Yes.
scanning the question and answer the questions on the
Yes, sir.
screen. Okay, one by one. So what are the main steps of management in this case?
My main step of first line management is I will secure a good IV access and I will start hydrating the patient. Yes, hydrating the patient, and I will watch for again. I will watch for the urine output as I hydrate the patient. I will also go ahead. Hydration will be the main step. I will go ahead with at least 2 or 3 liters in the first step, so that I will watch how he is improving. And second step will be if the urine output continues to be low, I will also go ahead with soda bicarbonate infusion so that I can alkaline diuresis can be done simultaneously. And if the patient has a good urine output, I will continue the same line of treatment. If he has any decreased urine output, I will get a nephrologist review, and I will also plan for a dialysis.
Mhm.
I have three differential diagnoses. First is rhabdomyolysis. Second thing is as his temperature is not very high, I will not think of any heat stroke. First thing is rhabdomyolysis. Second thing can be any drug overdose. But yes, second thing I can think of any drug overdose. Third thing, any muscular dystrophies, but there is no previous history of muscular dystrophies.
Okay.
But
No,
because
this is
temperature is normal, I'm not sure of heat stroke, if I can go ahead with a heat stroke.
that's okay. Even if something is not in favor of yours, you still can go for differential. So, bit two, I mean, this is the case two, a
Yes.
20-year-old man with no significant medical history. So you can just read,
Yes.
I mean, no need to allow and then answer the question.
So, the first thing I suspect is an ischemic stroke in this patient. Because ischemic stroke in this one, there is no significant finding in this CT. So I will go ahead with an MRI of the brain.
Good.
Sorry, I didn't go through it.
Sorry. Yeah. Okay.
Yes, sir.
Would like to see MRI because this
Yes,
they
sir.
have changed. MRI is this, okay? This is MRI cut off one part of the brain. All right. So questions?
I'm thinking of central pontine myelinosis in this patient, and the main risk factor will be like a rapid correction of sodium in this patient.
Any other risk factor?
Can you go for the previous slide?
In general,
Factors.
for central pontine diagnosis, the risk factors.
Other than rapid correction of sodium, I'm not sure, sir. Sorry.
All right. This is the fourth question for you.
Yes, sir.
This is the CT scan. Okay.
Yes.
So what is the diagnosis?
She has a right subdural hemorrhage, SPH,
Next
with
line of management. Yeah.
with the midline shift. I will go ahead with the Barhol therapy. I will go call the neurosurgeon. I will go ahead with the decompression of the brain, sir. Craniotomy and decompression.
The next question. Right. Okay.
Yes, sir.
This is the MRI. Now this is the question. What is the finding here?
Is this a bilateral posterior circulation bleed? There is a bleed in the cerebellum and in the posterior the posterior circulation area, so most probably the cerebellum.
Management. Oh, sorry. Next line of imaging to confirm your findings, or what would you like to do? So do to confirm or anything else?
And CT angio, I'm not sure, sir. CT and probably an MRI brain, sir. Next line of
Okay.
imaging.
Yeah. Sorry.
MRI brain.
All right. Okay. Next question. Okay.
Yes, sir.
So this is the figure. I'm sorry, I could not give it over here due to some mismatch. Okay. This is your EEG recording. And now, what is the finding here? List two important lines of management for above findings.
Sir, I'm sorry, I've not gone through the EEG, sir. I don't want to.
No problem. How to skip?
Yes, I'll go through it, sir. Sir, I'm not sure of the findings, sir.
No
I will
problem. No,
go through the
no
image.
problem. No problem. Okay.
Yes, sir.
What is the finding over here? What does CSF analysis suggest first?
CSF analysis is suggestive of tuberculosis etiology.
Okay. Findings on MRI brain. And let's just pinpoint a finding. What is abnormal?
There is an hydrocephalus. I'm not sure of the MRI findings, sir.
No problem. And is management of case? What will
I'm
you
thinking of a tuberculosis, so I will start go ahead with an AKT4 management. I'll start with the first line of anti-tuberculosis drugs like isoniazid, rifampicin, pyrazinamide, and ethambutol.
for TB meningitis?
Yes, sir.
Okay. Your question?
Yes, sir.
This is the graph of ICP. Carefully examine the graph, and now based on this, what is the finding in this graph? List two important lines of management for above finding.
So there is an increase in ICP because the B2 the I have to go through this, sir.
Okay, no problem. A 34-year-old, so this is the patient for you. This is the question. Just accumulate information.
Yes, sir.
Okay. So this is the graph, and based on this, what are the most likely cause of her weakness? and list 2 decorative management steps.
Dropping left eyelid and opportunity. She has a significant facial weakness. Likely cause of her weaknesses.
So what is the diagnosis? Okay, we'll go. I'm sorry, time is out.
Okay.
Another question?
Yes. Yes, sir.
So these are 2 graphs. One is NCB, another one is EMG.
Okay, sir.
So what is the most likely cause of her weakness? And 2 definitive management steps.
Sir, I'll think of a critical illness neuropathy in this patient first. Cause of her long-term ventilator setup. And improving her nutrition and slowly weaning from the ventilator will be the definitive management of this patient, sir.
Okay, good. Nice. So thank you so much. So how
Thank
was
you,
it
sir.
from your end? How were the
Sorry,
questions?
I have not prepared for the nervous systems graphics, sir. I'm going to appear in the May EDIC. I just want to give a trial of how the pattern will be. So,
No problem. You have enough time.
so I have, yes,
Yeah.
sir. I will go through those graphics and other things, sir.
Sure. And the time pressure, could you feel the real time examination environment?
Yes, sir. It was good, sir. I think the
Right.
time was adequate. If I could know the answers and the graphics, if I had gone through those well, I think the time was quite adequate for answering.
Yeah. Only thing is that probably you have to read fast, because the questions could
Yes,
be
sir.
very big, especially in
Yes, sir.
CBA, and the CBA are very scoring. You get a lot of scores if you
Okay.
answer quickly.
Okay, sir.
1 minute, they won't give much time in CBA. 1 minute only, 1 minute,
Okay.
maximum 1.5 minutes for each CBA. That is the only thing.
Okay, sir.
Neurology
Okay, sir.
is difficult because it has a lot of graphs, and we will discuss all these things, okay, in the next tomorrow's session, inshallah. Okay, thank you
Sure,
so
sir.
much for your attempts. All the best. So
Thank you, sir.
let's finish for you. I will take another candidate.
Yes.
Thank you.
Thanks a lot, sir.
Thank you.